Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Pediatric Pain Control, Episode 1, Safety and Efficacy. After watching this episode, participants should understand why pain control is appropriate in pediatric patients, understand common myths about pain medications in pediatric patients, understand the onset, duration, and mechanism of action of common pain medications, and understand safety concerns and side effects with use of pain medications in pediatric patients.
For a long time, it was thought that infants did not perceive pain in the same way as older children or adults did. There's been a great deal of research recently showing that unfortunately that is not true, that unfortunately infants do perceive pain just in the same way as we adults would. Therefore, there's been a huge movement towards pain control, even with heel sticks or minor blood draws in the newborn nursery. Some of this research has been done here at the University of Rochester, but it's also been reproduced nationwide. And therefore, I think it's really important to remember that even if you're dealing with the youngest of infants, if you do need to do some type of blood work on them or place an IV or do any type of procedure that might be painful, you need to be very aware that they need some comforting measures. Now, in an infant, it could be something as simple as allowing them to eat during the procedure. Either breastfeeding or taking a bottle has been shown to be very, very soothing to the infant. Interesting work has been done that has shown that sugar actually has a great analgesic effect on babies. So in the emergency department, we'll often allow the baby to suck on a pacifier that's covered in sugar water, and that triggers the same receptors in the brain as some of the stronger pain medications would, and will often quiet an infant and make them feel much better. We feel that this is so important because studies have shown that children who experience a great deal of pain in infancy go on to have difficulties with perceiving pain and having other emotional difficulties later on in childhood and in adulthood. So whatever we can do to get them off to a good start and to make sure that their pain is well controlled, I think that that's really important, whether it be in the ED or in the pre-hospital environment. Children, on the other hand, they're going to usually be very clear about what pain they're having, and they will often fear the worst and have their pain be heightened by any anxiety or fear that they have. It's very normal for a toddler to have a significant amount of strain or anxiety, and then of course that'll be compounded by the fact that if they do have an injury, perhaps a broken arm, or if they're just generally feeling ill, everything will be made much, much, much worse in the child's eyes. So in those situations, it's not unusual where we kind of have to go above and beyond what we would think we would need to do to offer comfort to that child. So whether it be sitting on a parent's lap and having a stuffed animal, and if the situation is appropriate, a popsicle, we will often do that just to make sure the child is more comforted. I think I can't underscore the importance of parental involvement in the evaluation and treatment of any child. They're the only familiar face to that child, and they will bring a great deal of comfort to that child. The caveat here, of course, is the parent has to be comfortable and calm in the environment, which understandably is not always something a parent can do in the setting of a significant trauma or a significant illness.
So the mechanism of action of morphine is that it is an opioid agonist, and it works directly and specifically to mu-opioid receptors. Now, the way it produces analgesic effects is that it works on the mu receptors that are located in the central nervous system and actually decreases the pain perception at that site. So there's a lot of different routes of administration for morphine. We can give it IV, IM, orally, in the cheek, buccally. It can be intrathecal as a suppository, transdermal. So there's a lot of different routes of administration. Really, for us, the main routes are intramuscular or intravenous. The intravenous route is our quickest route, and the onset of action is usually about 5 minutes, and the duration of action can be about 2 to 3 hours. Where with intramuscular administration, the onset of action is about anywhere from 10 to 30 minutes, and the duration of action can be anywhere between 4 and 5 hours. So the IV route of administration for morphine is our ideal route, but we can give it intramuscularly if we don't have IV access. The morphine, though, itself is a hydrophilic drug, so meaning that it causes some variable absorption and distribution in the tissue compared to some of our lipophilic drugs or analgesics that we have, like hydromorphone or fentanyl. So when I discuss the onset of action of morphine, that's why there's such a variability in the onset, being anywhere from 10 to 30 minutes. But if we don't have access, obviously that's going to be our best route of administration.
So to review, morphine is a mu agonist most commonly given through the IV and IM routes. The IV route has an onset of about 5 minutes with a duration of 2 to 3 hours, where the IM route has an onset of 10 to 30 minutes and a duration of 4 to 5 hours. Most commonly, the dosage is 0.025 milligrams per kilogram to 0.1 milligrams per kilogram, always remembering to follow local protocols.
As a paramedic, I've always had some concerns with administering morphine in any patient population, whether it be pediatrics or geriatrics. You're always afraid of overdosing them, sedating them too much, or depressing their respiratory effort. To overcome that, just know your doses, know you have an antidote for the narcotic analgesic, and keep assessing them.
So the side effects of morphine are basically from the actions on the mu receptors that are outside of the central nervous system. So because you do have mu receptors elsewhere in the body, that's what causes the sedation, respiratory depression, decreases in GI motility that you can commonly see from morphine, also the decreases in blood pressure as well. So when discussing morphine and the use of morphine, morphine is a relatively safe drug, although it does have some of the side effects that I discussed of respiratory depression and sedation. Pretty much the doses that we're giving, there's pretty much a dosage range of anywhere from 0.025 milligrams per kilogram up to 0.1 milligram per kilogram. And usually we start on the lower end of the dosing range. And it's important to make sure that we're properly giving these kids analgesia and not so much worrying about some of these adverse events, because we do have the tools in the pre-hospital setting to be able to reverse the effects of morphine and support respiratory depression if that occurs.
In review, morphine side effects result from action on mu receptors outside the central nervous system. The primary concerns to EMS providers are sedation and respiratory suppression. However, most EMS providers should be well prepared to deal with these side effects. Treatment of side effects might include respiratory support using positive pressure ventilation and naloxone at a dose of 0.1 milligrams per kilogram in accordance with local protocols.
As far as treating kids' pain with morphine as a paramedic, it's an invaluable tool to have in the toolbox. These kids are already scared, they're in pain, sometimes they can't quantify or qualify the pain they're experiencing. It helps calm them down, it makes them more relaxed, it allows you to assess them better.
I think morphine can be very helpful with getting the child's pain under control. I think it's underused before they get here, especially in acute settings. So sometimes it's easier to get a kid's pain under control, you'll get much better cooperation. So generally speaking, I don't have a lot of concern about using morphine in small children. It's easily reversible, and just being able to maybe learn or get comfortable with estimating a child's weight would be your biggest hurdle to get over, and then you get more comfortable with using it. When we use morphine in children, watching their respiratory status is a big thing. So actually getting a respiratory rate before you take it or give it, and watching for any CNS depression. But generally kids react fairly well to it.
We often hear pre-hospital providers say, I was concerned about placing an IV in this child. A very small child, or a child didn't have good veins, and my thought was we were so close to the hospital that once we got here you guys would be able to give the child morphine. And that's true. We will work as fast as we can to get pain control into a child should they need it upon arrival to the ED. Unfortunately, some recent studies have shown that children who arrive to the emergency department via EMS without any prior pain control actually are waiting longer for IV or IM or narcotic pain medications than their counterparts who just arrive via their parents' vehicle. What that means is that I think we're all falsely reassured that we get pain medicine into our patients as fast as we like to think we do. Therefore, I can't encourage you enough to develop your own comfort level with giving pain medications to children, whether it be placing an IV and giving that medication IV, or whether it be giving them a shot. Yes, children don't like shots, but they will forgive you if they get great pain control from the medicine that you give them. And of course, good pain control means better assessment, means a more stable patient, and an overall better care environment for the child.
After watching this episode, participants should understand that pain control is appropriate in pediatric patients, although commonly overlooked or underemphasized. Additionally, providers should avoid deferring administration of pain medication in hopes that the hospital will provide it. Participants should also understand that morphine is the most commonly used pre-hospital pain medication and that its most concerning side effects are generally easy to manage or reverse.